This is Creating a Family. Talk about foster, adoptive, and kinship care. Welcome back to our regular listeners. You are valued. We appreciate you. And a special shout out to our new listeners. We see that our numbers are growing. We're getting more of you, and we're really appreciative of you joining us. I am Dawn Davenport. I am the host of the show as well as the director of the nonprofit, creatingafamily.org. Today, we're going to be talking about evaluating risk factors in international adoption. We will be talking with Dr. Dana Johnson. He is an MD, PhD, and is a professor of pediatrics in the Division of Neonatology at the University of Minnesota Medical School. Dr. Johnson founded the International Adoption Clinic at the University of Minnesota. His research interests include the effects of early institutionalization on growth and development and the outcomes of internationally adopted children. Welcome, Dr. Johnson, to Creating a Family.
Well, thank you so much, Don. It's a pleasure to be back with you.
Do you have an estimate on about how many referrals you have evaluated at the International Adoption Clinic at the University of Minnesota?
Well, I did count them up a few years ago, and I have talked to probably close to 30,000 families over my career in adoption medicine, and we've done even more than that in terms of actual reviews of kids.
Yeah, that's amazing. It's truly amazing. You are both a pioneer in this field as well as one of the most knowledgeable people I know. So without further ado, let's jump into it. Prenatal exposure to alcohol and drugs. I want to start with that. How common is this in international adoption?
Well, we do certainly see it. A lot of it depends on the history that we get from the child, and that varies tremendously between countries. For instance, in Korea, they almost always have information about alcohol and drug exposure. Taiwan is the same, but in many other countries, it's not mentioned. Sometimes we can tell, especially with alcohol, if children have facial features consistent with prenatal exposure. But often we don't know until actually the child shows up and ages a bit and starts off into school and starts having problems that might be related back to alcohol exposure in the uterus.
Do we know how much and when in the pregnancy? Let's separate alcohol and drugs. Do we know how much and when in the pregnancy? Do we have that information on most children being adopted internationally?
Well, we often don't. In terms of exposure, far and away, the most potent teratogen that causes problems in kids is alcohol. Mm-hmm. We know that a lot of kids are exposed to opioids or cocaine or marijuana, but the data on those exposures has not panned out to show tremendous problems like alcohol has. We know that alcohol is very potent and it can affect the baby throughout gestation. We know that the facial features that we consider as diagnostic of fetal alcohol syndrome usually come from exposure early in the pregnancy in the first trimester. But the brain effects, which are the ones that cause lasting problems in kids, that can occur throughout the pregnancy. But it's rare that we actually have the information to time when these drug exposures occurred. And in fact, we know that most women who use substances during their pregnancies tend to use more than one type. Mm-hmm. So they may use alcohol, but they also may use opioids. It's a complex issue, but I in particular spend a lot of time thinking about alcohol exposure because that is really the most important one to know about.
And as you mentioned, exposure to alcohol can cause brain damage, and that is a lifelong issue. So we will see the impacts in infancy, preschool, school age, young adults, the whole gambit.
That's exactly right. That's exactly right. And among the many factors that might stress families, raising a child with fetal alcohol syndrome or fetal alcohol spectrum disorder is a tough job.
All right. And you said that as far as opioids, cocaine, fentanyl, while it does have impacts, they are not as significant as the impacts from alcohol.
Right. Now, let me divide that into the impacts during the pregnancy and in the immediate postpartum period, and then long-term effects. What we don't know, and so far the data suggests that maybe it's not as big a problem as we thought, are the effects over the long term. These are psychoactive drugs. They can cause alterations in brain development, but the signs later on in life seem to be fairly subtle. They can have major effects on infants, of course, if they're withdrawing in the newborn period. and that can affect attachment with their parents and cause prolonged hospitalization. Agents such as methamphetamine and cocaine are very vasoactive agents and can cause alterations in placental blood flow. They can also cause strokes in babies prenatally. So they can have very profound effects on the developing fetus and in the newborn period.
What about marijuana? We certainly see that exposure during pregnancy is increasing in the United States. I don't know that it's increasing worldwide, but what about the impacts? Because it's legal, or some places it's legal, some places it's not, both in the U.S. and abroad. But we tend to discount things that are legal. But we certainly have seen with alcohol that is misplaced discounting. The only legal drug is certainly the most potent as far as a teratogen on fetuses. But what about marijuana?
Well, marijuana, again, is a psychoactive agent. It will cause alterations in brain chemistry. But again, we do not know the long-term effects of prenatal exposure and now postnatal exposure, too, if mom is breastfeeding and is also smoking marijuana, too. The recommendations now from the American College of Obstetrics and Gynecology and the American Academy of Pediatrics is that we really don't know the long-term effects, but our advice is not to use it during pregnancy and not to use it in situations where you're breastfeeding. I suspect it's going to take a long time to actually develop the data that will tell us whether or not there's an effect. But I think, if we want the healthiest child that we can have with the greatest chance of normal brain development, I personally would advise people to avoid doing that type of thing.
Of course, the reality is who we're talking to here are people who are adopting, not the people who are utilizing it. Right.
Exactly.
Right. What about cigarettes? Cigarette smoking in certain parts of the world is far more common than it is in the U.S. And again, it's legal, so we tend to discount the impact. Can cigarette smoking in pregnancy impact the fetus and the child?
Yes, we do see pretty significant impact on the fetus. The most common one is restriction in growth. Babies who are born of cigarette-smoking moms are generally, perhaps half a pound to a pound lighter than they would be otherwise. And then there are some long-term effects, too. We know that the incidence of sudden infant death syndrome is higher in moms who have smoked or are smoking at home. And the incidence of reactive airways disease or asthma is also higher in these children as well.
And that can last later into life as well?
Exactly.
Interesting. All right, let's talk about prenatal stress or maternal stress during the pregnancy. Generally speaking, when children are adopted internationally, we don't know what their maternal stress levels were during pregnancy. You seldom get that information, but we can assume that things weren't going smoothly, or the child would likely not have been placed in an orphanage or in state care. So what do we know about the impact of maternal stress on the long-term health of the child?
Well, we know a lot. First of all, many, many years ago, people figured that the baby was immune to what was going on in the world. They were in this little bubble and being taken care of by the mother and the placenta, and things that stressed the mother weren't going to really bother the baby. We know now that our development is determined not only by our genetics, but also by the environment. So if you have an adverse environment, it certainly can affect the baby. So we see this the most, and this has been documented the best in terms of things like medical illness in the mom. So if the mom is ill and, for instance, has very high blood pressure, the placenta is not functioning well, the baby's not getting enough blood supply and oxygen, that baby will be small. And not only will the baby show immediate effects from that, but over the lifetime, that child who was born growth restricted is going to be at much higher risk of a lot of problems, including some of the chronic diseases of adulthood, like diabetes, high blood pressure, heart disease, high lipid profiles. This is called fetal programming. So if an infant is in an adverse environment, the body learns to do things to provide additional guarantee that that child will survive. Unfortunately, that can lead to chronic disease in older individuals. So we're just starting to learn about what, instead of medical problems, what the emotional status of the mother is will affect the baby. And we're just learning this now, but there are many different mechanisms that have been postulated, much as you mentioned, in mothers who are having a hard time and are the ones who place their children for adoption, might adversely affect both the short-term and the long-term outcome of kids.
Let me pause here for a moment to tell you about our Facebook support group. You can find it at facebook.com/groups/creating a family. And it is a terrific place to hang out with other adoptive parents and adoptees. And we do have a few birth parents as well. It is a supportive and safe place to be. So check it out, facebook.com/groups/creating a family. Now, moving on to mental illnesses. Again, we don't often know, but sometimes we will get information in international adoption reports on the child about the mental health status of the parents. So how heritable are mental illnesses? And I'm going to list the top 3, and you can throw out some other ones. Depression.
All the major affective disorders, and that would include depression and bipolar disease and schizophrenia, have a very strong hereditary component. But as I mentioned before, we're learning now that it's not our genes only, it's the environment in which we grow up in. Mm-hmm. So the nice thing about talking to families about mental illness and the parents is knowing that, yes, there is a risk and it's passed on through the genes, but the environment that a child grows up in, or the adoptive home, has a major effect on whether or not those genes are expressed. So the risk of depression, the risk of schizophrenia, the risk of bipolar disorder goes down if children are brought up in an environment separate from the birth parents who have those disorders. Mm-hmm. So they really have a major role in whether or not those genes might be expressed. Doesn't take the risk away, mm-hmm. but it reduces it.
How about ADHD, attention deficit hyperactivity disorder?
Yes, ADHD is another very highly hereditary disorder, but again, it requires an environmental input as well. ADHD is the single most common mental health problem that we see in adoptees. And there's probably a couple of reasons for that. One is that there is probably a hereditary component that comes along with that child, but also the environment that they're in, especially if they've been institutionalized, will bring out that disorder in a way that may not have come out if they had been raised in a loving and nurturing family.
Mm-hmm. How heritable is intelligence or academic success?
Well, I think that intelligence certainly has a hereditary component. Bright parents usually have kids that are fairly bright, but it's also an environmental thing because bright parents usually provide an environment that's mm-hmm. very conducive to their kids' academic achievements. Innate intelligence is very important, but the environment in which a child is raised is also very important in terms of how they're putting their innate intelligence to use. And again, adoptive families can have a profound effect on how well their kids do in school and how well kids do in life. I mean, we know a lot of smart people who don't do particularly well in life.
That is so true. Intelligence only gets you so far.
That's right. And we know a lot of people who have low normal or kind of average intelligence who thrive and do extremely well because they have the social skills and the determination to do it. So those are things that adoptive families give their kids.
Mm-hmm. Yeah, persistence and social skills will make up for a huge amount. They really will. They really will. All right, let's talk about attachment issues. It is certainly something that we hear a lot about mm-hmm. in international adoption. So how common are attachment struggles with international adoption?
Okay. So we'll assume that kids are coming out of environments that predispose kids to attachment problems. So these are environments where they're not getting any individual attention. They're living in an orphanage where they're just one of many that need to be taken care of. No one's really nurturing them in an appropriate way. So there is a baseline risk of attachment disorders. And a few years ago, the psychiatrists got together and revised the DSM Diagnosis and Statistical Manual to change the diagnosis of attachment disorders. So now there are 2 types of diagnoses that we can use. One is the kind of traditional reactive attachment disorder that we see where children do not want to interact. They get hurt. They don't go for help. They don't want to make an emotional bond. They have emotional liabilities, difficulty sharing affection. And I think that's what families fear the most, is mm-hmm. that's what's going to happen in that situation. What we found in the Bucharest Early Intervention Project, which is the first controlled study of orphanage versus foster care, is that the kids who went into the foster care system had a precipitous drop in their symptoms of reactive attachment disorder, to the point where very few kids actually exhibited those symptoms after they had been in their family for a while. There's a second type of attachment disorder now that's recognized, and that's called disinhibited social engagement disorder. These are the kids that love everybody, and they have not really made a specific bond with someone, but they're out looking for interaction with everybody. That poses two problems. One is that it can be a danger to the child because they'll be in the store with mom and suddenly they're walking off with a stranger because they didn't care that it wasn't mom. They're willing to go with anybody. And then the other thing is that it disappoints families and parents, especially because, they're not special people. If everyone's that child's friend, then they don't have that special bond with the family. That's much more resistant to nurturing care. It does get better with time, but it does persist. Now, there are a couple things I would say about attachment problems. One is if you go through the internet and look at symptoms of attachment disorder, it's a long laundry list of just about anything that can go wrong with kids. A lot of symptoms are applied to the diagnosis of attachment disorder. The second thing is attachment is a specific task of early childhood, and people have extrapolated what happens in kids to older kids, and that may not be appropriate. There may be other diagnostic categories that may be more appropriate for older kids other than just attachment disorders. The other thing is I always encourage families before they start seeing someone for attachment therapy that basically they have a full evaluation of their child, because there are medical and neuropsychiatric issues that can mimic some of the symptoms that are listed under attachment disorders that actually are totally different and more amenable to treatment. So for instance, kids who may not want to be touched, they may not have attachment disorders, they may have sensory integration problems. And touching them is a very noxious stimulus for them. So they don't want to hug. They don't want to be in close contact. And with appropriate sensory integration therapy, that can be taken care of. There are other kids who don't seem to want to be interacting because they can't hear or because they can't see. There are some kids who are behaving abnormally because they have profound mental retardation. So I think it's imperative that families talk to their physician, make sure that there are no medical issues, especially hearing and vision issues and sensory integration issues that are present, and that they have a full neuropsychiatric evaluation just to know what their child's strengths and weaknesses are before they embark upon a course of attachment therapy, which may not address the primary issue in the first place.
I am loving this interview with Dr. Johnson, like I always do. He is such a valuable resource. But I must interrupt to tell you quickly about the free courses that we are offering on the Creating a Family website. These courses are brought to you through the support of the Jockey Being Family Foundation. There are 12 of them. They are self-paced. You take them online, and they're 1 hour each. Check it out at bit.ly/JBF support. That's bit.ly/JBF support. All right. What are the impacts of neglect, and how common is neglect in international adoption? There's a tendency to think, oh, it's just neglect, it wasn't abuse. But what are the impacts and how common is it?
Well, interesting. People have actually looked at the long-term effects of neglect versus abuse. And it turns out that neglect is worse. If no one's paying any attention to you at all, that's worse than someone paying attention to you, even if they're hurting you doing it. Neglect is probably the worst thing that can happen to kids, and that's what we see in kids in institutional care settings. They are not getting that one-to-one care. They're not getting that nurture that they need. There's no way that they can form an attachment bond. When we think of a child growing up in a family, even a big family, there's a fair amount of one-on-one attention that infant receives. But when a child's in an institution, over the course of a year, they may have exposure to hundreds of different individuals, none of whom look at that child as a special child necessarily. So the whole process of growth and development is highly dependent on that nurturing that occurs between the primary caregiver and child. And without that, motor development is impacted, growth is impacted, nutritional status is affected, speech and language is affected. That whole attachment cycle doesn't happen. Neglect is very bad for babies.
How often in international adoption referral reports do you see evidence of or acknowledgement of physical abuse?
We do see it, especially in the older kids that are coming out of dysfunctional families. So, for instance, we see this a lot in Colombia. We see it in Taiwan. We see it in Korea on occasion. But these are countries where there's a very in-depth report on the family and the reasons why that child is available for adoption. And they send us these reports, all 50 pages of them, that go into great detail, sometimes about how kids have been certainly neglected, often abused, and sometimes sexually abused too. I would say it's unusual in institutional care for very young children to have a history of either sexual or physical abuse. Older children above the age of maybe 5 or 6 who are in institutional care will often be prematurely sexualized because they'll see sexual activity that's age inappropriate. And if you get up into the teenage years, there's a lot of child-to-child sexual abuse, as well as some adult-to-child sexual abuse that happens too, although we often don't hear about that in reports.
If I'm hearing you correctly, we don't see it in the reports, but you do see it after kids are home and are in their families, and you see evidence.
Yes.
And also they can talk after they learn the
Right.
language, they're able to share what happened.
Exactly.
Many of the kids coming to us through international adoption, their mothers had very little prenatal care. What would be the significant impact of lack of prenatal care?
Well, lack of prenatal care, the two major things that happen is that babies are delivered prematurely and that babies are delivered growth restricted. So we talked a little bit about a growth restricted baby and some of the long-term issues that happen to them, development of adult diseases that may impact their lives. Prematurity does the same thing. Anytime you're born a little bit early, you're a higher risk for mental retardation, learning disabilities, even autism, physical and motor delays. Prenatal care is very important to make sure that everything goes well in the pregnancy and that the child has the greatest possibility to thrive.
Did you know that we now have 2 podcasts? We have this one, and we have one that is a much shorter, usually 5 to 10 minutes, where we answer a question from our audience. What we need from you is your questions. So please submit questions to info@creatingafamily.org. It will find its way to me, and I will answer it on A Week in Wisdom. Send us your questions to info@creatingafamily.org. All right, I'm going to ask you to go through a list of conditions and ask how common are the following in international adoption. Let's talk about hepatitis B and where is it most prevalent?
Thankfully, hepatitis B is one of the great success stories around the world in the last few years. When I started, most of our kids, 2/3 of the kids came from Korea, and hepatitis B was a huge issue. Hepatitis B is very common in Asia. We saw a lot of transmission of hepatitis B from moms to children, and the incidence was up to 20% in adoptees. Now, since then, we've had the introduction of hepatitis B not only domestically, but around the world. And by the end of the 90s, hepatitis B was down to 2.8% in international adoptees. And when we looked between 2006 and 2012, it was down to about 0.5%. Hepatitis B still occurs. It's a very infectious organism. If mothers have it and the babies don't get appropriately treated, it can be passed on to 80 to 90% of kids. And it can be a lifelong infection, and it can cause liver failure, although usually not in childhood. And it can cause malignancy, liver tumors, usually later on in life. But thankfully, with the use of hepatitis B vaccine, we're not seeing it nearly as much as we used to be.
What about hepatitis C?
Hepatitis C takes a much, much bigger amount of blood to actually infect you. The titer of the virus in an infected person varies, but it's quite low. And where we usually see it is in situations where mothers are IV drug users, because that's a situation that puts moms at much higher risk of hepatitis C. Thankfully, there's not much maternal to infant transmission.
Interesting.
It's probably less than 5%, again, because you need a lot more blood to transmit it. The other nice thing about hepatitis C, which is about less than 1% of international adoptees, is that there is very good treatment for it now, as opposed to hepatitis B, where we still don't have a good treatment. So I think the situation for hepatitis C is just to make the diagnosis. It can cause long-term effects, but we can treat it, so it's always good to know if it's there.
What about HIV?
Well, HIV continues to be a problem. Again, it's not as transmissible from mothers to infants as hepatitis B is, but it does occur. And it also occurs in transmission if the mother had the baby for a while and breastfed the baby. HIV can be transmitted that way as well. Now, HIV testing is really quite good around the world. And all of our children almost all are tested for HIV at appropriate times. So the incidence of HIV in kids who are being adopted is relatively low. We do see a number of children who do have HIV who adoptive parents have sought out because they want to adopt a child that has HIV. And that's usually the situation. The kids who are adopted as normal kids without HIV, who later turn out to have HIV, it still happens, but it's relatively infrequent.
What about congenital syphilis?
Well, congenital syphilis, again, it depends on the country. For the most part, I would say that the incidence of congenital syphilis remains low in international adoptees. It's less than 1%. And with appropriate treatment, the outcome can be quite good. There are places where we saw a lot more syphilis. Of course, we're not seeing any kids come from Russia, but we did see a fair number of cases of congenital syphilis in Russia. Right now, the one country that's placing in the United States that I would be concerned about congenital syphilis is Haiti, where the medical system is totally broken. Mothers are not adequately screened and treated. So we do see kids with congenital syphilis from Haiti.
How common is prematurity?
Because moms don't get prenatal care, the incidence of prematurity is probably 2 or 3 times higher in kids who are candidates for intercountry adoption than they would be here. That is a major issue. India, in particular, places a lot of very, very low birth weight babies.
Why India in particular?
Well, because they have a lot of them. There's a lot of malnutrition. There's a lot of poor prenatal care or no prenatal care in moms in India because they don't want to acknowledge that they're pregnant or acknowledge to the family that they're pregnant. And it's just an environment that predisposes. The other thing is that almost all the kids that are being placed for intercountry adoption right now are kids with special needs. And that just happens to be a very common special need in India right now. India places a lot of kids domestically, but families get to choose the most robust kids for domestic adoption, and those who aren't placed for domestic adoption are offered for intercountry adoption. And so those are the kids with the greater problems. So I think that's why we see so many from India.
That makes sense. What about low birth weight without prematurity?
You can be small because you're premature and you can be appropriately growing for that gestational age. Or you can be small because you've been starved in utero and be small for gestational age. So the kids that are premature, that are normal size, are born, don't have major medical problems, and grow well, although that's not the majority of kids who are born prematurely in most countries, you wouldn't necessarily be at the same long-term risks that a baby who was small for gestational age had been starved in utero.
Mm-hmm. Yeah, that makes sense. What about cleft lip, cleft palate? That used to be a fairly common special need that we see. Is it still a common one?
It is. It is. I would say that in countries with good medical care, these are countries that place for intercountry adoption that have high standards of living and are in the upper economic range, such as South Korea. There are more families who are accepting cleft lip and palate domestically than there used to be. But, it's still a special need, and we do see kids with cleft lip and palate coming from Korea. It's 0.5% of the kids in the general population, but of course, in our population of intercountry adoptions that are all special needs, we see a lot more of those. Yeah. What I would say about cleft lip and palate is the prognosis is very good, but parents should plan on taking them to a recognized cleft lip and palate clinic. Not only is there surgical care there, but there's all the other disciplines that are needed to rehabilitate a child with a cleft lip and palate. ears, nose, and throat surgeons, speech and language pathologists, dentists, etc., all play a role in rehabilitating kids with cleft lip and cleft palate.
Yeah.
There are cleft palates that are associated with syndromes. There are cleft lip and palates that are not associated with syndromes. What I would say is that families who are looking at a child that just has a cleft palate, those are kids that are more often than not associated with other problems, other syndromes. Cleft lip and palate together are less likely to be associated with other problems.
And when you say other problems, give us an example of some of the other conditions that could be accompanying a cleft palate.
Chromosomal abnormalities, kidney problems, heart problems, things like that.
Okay. Speaking of heart problems, how common are congenital heart issues?
Well, congenital heart issues, like cleft palate, is about 0.5% in the general population. But, again, we're dealing with a special needs population, and a lot of these kids do have congenital heart disease. The largest number of children with congenital heart disease when we were seeing children coming from China. We would see a fairly large number of kids who had ongoing congenital heart problems or kids who had them repaired. China has a very robust congenital heart disease program, and there are ways of kids in orphanages for getting appropriate care. So we would have kids, in both situations with diagnosed and undiagnosed problems.
I would assume most of these would be diagnosed prior to placement.
That's true. But we have had kids with congenital heart disease that has been diagnosed after placement. It's uncommon, but with anything, don't always assume that the diagnoses are going to be made in the country of origin.
Yeah. How about missing limbs or digits or amniotic band syndrome?
We did see a fair number of kids with amniotic band syndrome or the missing limbs. It's also called amnion disruption syndrome, where little pieces of connective tissue get wrapped around digits or whole arms or even heads and cause tremendous malformations or autoamputations. So we would see these in countries where there was probably a high incidence of attempted abortions. And we saw this in Russia and we saw this in China.
How does that connect to the two?
Well, if you go in and you try and instrument, try and either kill the fetus or induce pregnancy, you're going to have a chance to rupture the amniotic membranes, and the remnants of those membranes will get wrapped around the extremity and cause the amputation.
Interesting.
Yeah, that's my speculation, but that's where we saw a lot of kids with amnion disruption syndrome.
That would be China and Russia, but you're not seeing it as much now.
We are seeing it less now than we used to.
How about albinism?
Well, China was another place where we saw a lot of kids referred for albinism. Albinism is very infrequent in the general population. It's like 1 in 17,000. There are two major problems with albinism. One is that all kids who have albinism have vision problems. And this can range from nearsighted, farsightedness, astigmatism, to much more significant problems of reduced vision with retinal problems, or nystagmus, where the eyes go back and forth rapidly from side to side. These are kids who need to be followed by ophthalmologists, and families adopting kids with albinism have to recognize that there's a very high likelihood that there are going to be vision problems. The other thing, of course, is lack of melanin, which is the pigment that protects us from ultraviolet radiation. So these kids are easily sunburned and have to be very careful about sun exposure. They also have a high risk of developing skin tumors, which can be fatal. Again, it's a long-term issue usually, but it requires constant monitoring by the families when these kids are small to make sure that they stay out of the sun.
All right, dwarfism.
Two most common situations that we see associated with short stature in international adoptees is just linear growth failure that comes with lack of nurturing. You think that all growth is just dependent on food. Well, it's a combination of food and nurture. And we see pretty profound growth failure in terms of linear growth in kids in institutional care. The other is nutritional. We see kids with rickets who are short. The prognosis for both of these in terms of height is quite good. Once kids get into families, they start growing like crazy. And with vitamin D therapy, in the vast majority of kids with rickets, they'd attain normal height. We do see kids that are referred with specific dwarfing conditions, and it's often hard to make that diagnosis before that child arrives. Again, if they're in a country with a good medical system, they can get bone films, which can be diagnostic of a particular type of dwarfism. But sometimes the true diagnosis or a certain diagnosis can't be made until the child is here.
And not able to distinguish between the growth impairments caused by lack of nutrition or by lack of nurture.
Right.
It's hard to distinguish. That makes sense.
Exactly.
So what are the most common special needs you are seeing right now?
Oh, good question. Oh, I think prematurity is a major one. And it kind of all depends on the country and how many they're placing. So we see a lot of kids being placed from India. Again, prematurity is far and away the most important thing we see there. Korea, cleft lip and palates, alcohol exposure, prematurity are probably three of the most common things we see from Korea. In countries that place older kids, such as the Philippines and Colombia, it's, family situations that caused disruption of the family, alcohol and drug exposure, abuse and neglect. Taiwan, a lot of families with long histories of mental illness and sometimes neglect and abuse as well. Since the numbers have gone down so much, we have a number of countries with kind of a handful of kids, and really you can see just about anything. I'm spending time talking to consultants and looking online for diagnoses frequently when I'm reviewing now, because we see such a potpourri of different conditions that children may be coming with now.
That's interesting. It's interesting how things have changed in the last X number of years. Yes.
Oh, yes, absolutely.
Yeah. What is the risk to the child if the birth mother has or had tuberculosis?
If the birth mother has tuberculosis and that child does not live with the birth mother, and again, we're assuming that she has active tuberculosis and she's coughing out organisms that can be transmitted to the baby, there's very little risk of a child acquiring tuberculosis just from being inside the mom and gestating. They really have to be exposed after birth to a mom who is infectious. We do see transmission of tuberculosis in institutions where they're not screening their staff. We see situations where foster parents aren't screened for tuberculosis, where children come into contact with TB. But if the mom has TB, chances are that child is not going to be exposed. Most children in countries outside the United States get a vaccine for TB very early in the first year of life. It's called BCG vaccine. It doesn't prevent them from acquiring tuberculosis, but it prevents them from having disseminated disease, or it reduces the risk of disseminated disease.
And what does disseminated disease mean?
Disseminated disease means that if I caught tuberculosis, it would be in my lung, my immune system would keep it in my lung, and it wouldn't be disseminated out to all my organs. For a baby, their immune system, especially the cellular immune system that is primarily responsible for fighting tuberculosis, is not as well developed. So if that baby inhales tuberculosis or swallows tuberculosis in, for instance, infected milk, that tuberculosis organism will disseminate out into a number of different organ systems. It can cause meningitis. It can cause osteomyelitis in the bones. It can cause disseminated gastrointestinal TB. It can go basically anywhere and cause disease, which is a much, much more severe and life-threatening condition than just a focal infection in the lung.
Mm-hmm. But it's not a particularly common thing you are seeing, however.
We do see kids who have been exposed to tuberculosis because tuberculosis is prevalent in the country that they come from, especially right now, Philippines and countries in Africa, but it can be anywhere. So we'll have evidence of perhaps 20 to 25% of kids have been exposed to tuberculosis, but they don't have active disease. So this is called latent tuberculosis. It means that somewhere in their lung, a tuberculosis organism is hiding. It's alive, it's contained, but at some point in the future, especially when immune system is compromised, there's malignancy, there's malnutrition, something that would reduce your immune system's ability to contain that organism may come out and cause more disseminated disease. So what we want to do in those situations is recognize that they have been infected, and we want to give them a treatment that can range from 3 to 6 months, depending on the drug that's used, that will reduce dramatically the risk of disseminated tuberculosis later on in life. So we strongly recommend testing for tuberculosis in kids who have arrived. And some would argue that we should test at the time of arrival and also 6 months later, because we find that nutritional inadequacies in children who have just arrived will sometimes reduce their reaction or ability to make that diagnosis of tuberculosis exposure. And after 6 months, they're in much better nutritional shape, and therefore their reactions are more appropriate. So yes, it's important to test for it. The treatment is straightforward. Children rarely transmit tuberculosis to other members of their family, so family doesn't have to worry about that. And it's important for the long-term health of that child.
Are there any other significant risk factors in international adoption that prospective adoptive parents should be aware of before going into it?
Well, I think that it's hard to make a blanket statement about risk factors other than the fact that if you are not nurtured, that's a risk factor. If you are premature or low birth weight baby, that's a risk factor. And if you're exposed to alcohol, that clearly is a risk factor as well. In terms of other disorders, I think that's where it's a good idea to consult with a knowledgeable specialist, especially if one is doing intercountry adoption, because there's less exposure of your general pediatrician and family physician to intercountry adoptions these days because the numbers are down so far. And a specialist who does intercountry adoption is going to be up on what the current trends are.
Mm-hmm.
And talking about the individual profile of a child and where there may or may not be things to worry about.
So, how do you find a clinic or a doctor that specializes in evaluating international adoption referrals? Because as you point out, it's important to find somebody who is, especially now that our numbers of international adoptions are down, how to find someone who is doing enough that they would know what to test for and recognize symptoms.
Well, the number of clinics doing intercountry adoption evaluations has dropped, along with the number of kids being adopted. Most of the adoption clinics have changed into adoption and foster care clinics, where they're taking care of kids in the foster care system too, because they have very similar profiles in terms of risk. So most major academic medical centers, so a children's hospital that's associated with a medical school, will have people who can help do that evaluation. Sometimes they're an infectious disease. Other times there's a separate adoption medicine program. Other times it's within general pediatrics. There are people who are knowledgeable and specialize in intercountry adoption. Google helps. I did a search yesterday for international adoption clinics, and a number of the ones that I'm aware of popped up. I think if families have a difficult time finding them, they can always contact the adoption medicine clinic at University of Minnesota. We can send them out a list of people who we know have been doing it. Whether they're still doing it or not is another question.
Mm-hmm.
Another way of doing it is to find a pediatrician in your community that's an adoptive parent. Generally, they are pretty knowledgeable about the field and can certainly either direct you to an adoption clinic or perhaps even see you themselves. The other thing is that the American Academy of Pediatrics section on foster care, adoption, and kinship care has published guidelines for how to evaluate kids after arrival. And it's very extensive, it's up to date, and it's very good. Parents can get a copy of that and educate themselves about what needs to be done. There are also publications that families may want to look for on the web, talking about the many issues that we do see in adopted kids. Knowing not just what to do in terms of screening these kids for potential health problems, but also getting some advice about how to make the transition from the environment that the child was in before into your home environment, what might happen, what's age appropriate, how to deal with issues from a knowledgeable psychologist who has worked with adoptive families in the past is often helpful. We're lucky in our clinic because we have all those people as part of our clinic. That's not always the case, but there are resources that you can look at for psychologists in your community that might help you make that transition a little bit easier.
And creating a family, we have a lot of resources to help families with transitioning, understanding trauma, understanding how to aid in attachment, things such as that. We have many, 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 many resources on all of those. In addition to the things that you mentioned, I would refer families there as well.
If I could make one important comment, is that making sure that families have appropriate expectations is probably the most important thing we can do.
I could not agree with you more.
It's interesting. I saw a poster presented at an adoption conference at one point about resources that families utilize, and then they graded the resources as how useful they were.
Oh, interesting.
Talking to a physician was the second most common thing that families did to learn about these issues. But the things that turned out to be even more important than advice from a physician is advice from other adoptive families, and resources like yours on the internet that parents can go to are very, very important in terms of setting expectations and being prepared for bringing that child into the home. We did a study in the early 2000s looking at almost 3,000 kids that had been adopted in Minnesota and over 1,500 families. And we asked them, how are things going? And over 90% said that things were going well, which I thought was very heartening. And this was maybe 5 years after the adoption had occurred. There were families that were having difficulty, but we know that preparing yourself for the adoption, getting medical evaluation, can really reduce some of the issues that tend to bother families after the adoption has taken place. So be informed.
And if you go in understanding, you are prepared for this and you're not surprised.
That's right.
It makes a huge difference. And it's seldom the physical issues that cause the problems. It is almost always the emotional issues.
Yeah. Eleanor Ames, who was a psychologist up in Canada, did a study in the Romanian adoptees after they were placed. And very shortly after arrival, the major concern that families had were medical issues. So she queried them a few years afterwards, and the medical issues had disappeared, and the behavioral issues were much more important to families at that point. So even though you're concerned about the medical issues, it's the other issues that are the ones that you really should be prepared more for.
The only thing I would say about the physical and medical issues is to be aware that it is time-consuming and prepare for that. Know that there's going to be appointments. There's going to be contacting specialists. If you don't live near a clinic, it's going to be driving. And also, if you don't live near a clinic and your child has a particularly unique issue, you're going to have to seek it out, and there'll be even greater travel.
Right, exactly. And some families tell me, well, we didn't get a medical issue because we knew that this was the child that was destined for us and we were going to take this child no matter what. And my response to that is, yes, I'm not going to tell you not to adopt your child. I'm going to tell you how to prepare for your child. And it's exactly what you said. If you have a kid with a complex medical issue, it's lining up that support before that child arrives in your family and making sure that you and your family are prepared to deal with the stress of that. And again, that's making sure your expectations are appropriate.
On that note, I want to thank you so much for talking with us today, Dr. Dana Johnson, about evaluating risk factors in international adoption. And before everyone leaves, I want to tell you about the 8th International Conference on Adoption Research that Dr. Johnson is helping to organize. And it is going to be July 8th through the 12th, 2024. The acronym is ICAR for International Conference on Adoption Research. So you can look that up on Facebook or LinkedIn or Instagram. It is a great conference, so check it out. If you're in the Minnesota area, or even if you're not and you want to travel, check it out. And again, thank you, Dr. Johnson.
Oh, you're so welcome, Dawn. It's always a pleasure.
Wait. Before you leave, let me tell you and thank one of our longest-term sponsors, and that is Children's Connection. Children's Connection is an adoption agency providing services for domestic infant adoption, placing babies throughout the U.S. They also do home studies and post-adoption support for families in Texas. Thank you, Children's Connection.